Hello, I'm Paul Laney, the retired sheriff from Cass County, North Dakota. I'm current vice president of national sales here at Turnkey Corrections, and you are listening to JailTalk. Now, today we're going to be doing something a little bit different. Lauren is on field assignment. Well, actually, she's sitting here in the studio observing, but saying she's on field assignment sounded way cooler. So, no, we are going to have two guests here today. As many of you know from our last episodes, we have Executive Director from National Sheriff's Association, Jonathan Thompson here, and our returning guest, Dr. Rachel Silva. We're going to talk a couple hot topics today. But before we get started, I want to say, if you like what we're doing here, please give us a like and subscribe below. Well, thank you both for being here today.
Yeah, it's great.
So now you guys, it's kind of cool.
Yeah.
You guys have known each other for almost a year. We kind of chewed a lot of crazy dirt together, but you guys got to meet each other for the first time today, and I think it's pretty cool. I got to facilitate that.
Oh, well, I got to tell you, what a great honor for me it's been, because I've seen the product, the work product, the deliverables of Dr. Silva, and for the longest time, it's a voice at the end of a line, or it's the digits at the end of your fingers, and it's been so rewarding and humbling for me, as I said yesterday, to be here and to just bask in the glory. I mean, it's
the aura of the
You guys are too kind.
All our joking around aside, though, you had such a major part to play, you and Dr. Stern, in getting us through the COVID response. I mean, I'm sitting here, and Jonathan has asked me to be the incident commander for this COVID-19 coordination cell. We're trying on a very high rate of speed, trying to respond to something we've never had to do before. We're trying to respond to the sheriff's needs across this country and work with the executive directors. And it's a medical pandemic. What do we know? We know emergency response. We know all that. You guys literally were our lifelink and our knowledge.
I'm giving a great shout out to Dr. Mark Stern in Washington.
Mm-hmm. Right.
He's the man we went to, and he said, we need somebody from the middle part of the country that has large agency experience, and I just am so honored that Sheriff Hutchinson from Hennepin County said whatever we can do to help, and Rachel, Dr. Silva, has been an enormous resource, and it for those watching, I want to tell you, whatever good came of our efforts, a lot of it right here, and a lot of it with Mark Stern, and we're just very thankful.
Well, I was an honor to be a part of that. I can say, even as a medical person at that time, we all were also sort of trying to figure out what was coming. And now, obviously, reflecting on the last year, have learned a lot and appreciate the ability to come back and speak with you both today about a really important topic.
And if you would have told me, I think it just kind of goes to show we're so used, I think, well, not only in America, but in the world, to kind of that instant solutions and instant gratifications, and the instant, everything's always fixed pretty fast. Here we are a year later, still wearing masks, still quarantining, still doing all that. What a dose of reality for everybody, because, we certainly don't have a crystal ball. We didn't have one then. I wish we had one. I asked for one every budget session. I really would like my crystal ball this year. They never gave it to me. Do you guys get those in the medical realm?
No, unfortunately not. We're actually, there's been studies that show that doctors are terrible at prognosis, for what it's worth. So I wish.
That's a different conversation.
That's a whole show right there.
Yeah. Unpack that. But
well, speaking of show, today we are going to talk something I know that you both are very passionate about, and it's something when Dave Mahoney, the NSA current national president, was here, he touched on it. We touched on it briefly with you. And then said, hey, let's do a whole show on it when you guys can really dive in deep with this. And that's the Medicaid exclusion rule that impacts county jails, which is something, obviously, as the NSA, you represent the nation's county sheriffs, and you are a medical director for a county jail, a very large one in Hennepin County in Minneapolis. And the impact it has with that. And I know it's something that we're going to talk about. What the exclusionary rule is once an inmate is booked into a jail, their Medicaid benefits end immediately.
Correct.
And if they're on a pretrial status for a year and a half, they don't have Medicaid. They don't have their benefits for a year and a half. And it's really an impact. And what happens, what a lot of people don't realize, and every sheriff listening here and every jail administrator listening right now says, absolutely, it goes back on the county taxpayer. And one medical, I ran a 350-bed jail. One inmate could wipe out my entire budget.
Yeah.
And that's a scary situation. When you start talking about that, and they came in with Medicaid benefits, they lose them the second they come in. So we're going to talk a lot about that today. And I know it's a hot topic for you, Dr. Silva. you're pretty passionate about this. So can you tell our listeners a little bit about the history of it and then why you are so concerned about this?
Sure. So, I think it's important to understand where we've been to kind of understand where things are at present and sort of where we can go from here. So, I had to look back at this history myself because it goes way, way back, actually. It was 1935 that this sort of developed with the Social Security Act. And then in the 60s with the Medicaid Act, it also got embedded in there. And the world looked really different then. In the 60s, incarceration rates were much, much lower than they are now. And so it's gone from a couple 100,000 people being in jails to millions. And from my seat, I do still see patients at our jail, and these days see quite a few. And it really impacts the decisions I have to make as a doctor. And while, often we have the fortune of not having to deal with budget and having the transparency about cost, it kind of pains me to have to decide, should this person get kind of the standard therapy, kind of what the guidance is telling me to do, or do I have to make a decision that says, well, I'll have to give them this treatment instead because it's cheaper. And that's a simple thing. We do that with diabetes medications all the time. But with things like COVID-19, I know a lot of jails have struggled with how much testing do we do? What's the right kind of testing? Should we only test people with symptoms and then we don't have to spend as much money? Is that really the right thing when you're dealing with a congregate setting? And then there's the folks who we know jails are filled with folks with mental illness, substance use disorders, and from a medical perspective, which is, my hat and the way I see the world, people need treatment. They need medications. They need treatment options. There's all these things that I think are jails could be much better prepared to help people with if there was money to do it and it wasn't a competition between deputy staff and someone's treatment and things like that. I think it would really help reframe all these problems as medical issues and help give a different perspective as well to have that support.
Well, there's also the moral issue, though, too, which is, and we've talked about this, Paul and I have talked about this for a long time, is that where does the obligation to treat start and stop? Mm-hmm. And it's different in a jail environment because you're regulated by the Constitution and the courts.
Absolutely.
And but when that inmate or inmates leaves that setting, that doesn't exist anymore. And when they can't transition from care in a jail setting to continuity of care outside the setting, we all know what happens. They lose their coverage, right? They lose their access to treatment, and they lose precious time. If they're diabetic, mm-hmm. they're gonna find themselves where? Back in an emergency room. Mm-hmm. They're going to leave the emergency room. They're going to be high risk. They're going to be at need, and it's going to lead to another vicious cycle of crime in the more likelihood. And that's a moral conundrum that we can't. It seems to me it's an easy answer. It's fix it up front. It solves itself at the back end. And it's what's the old adage? Pay me now or pay me later. Exactly. Well, paying me later, it's going to be sometimes they're looking at 1,000% difference.
And even and I also practice in a primary care practice, so I see people who have left jail and sort of don't have benefits, and it's definitely a much bigger process to get folks kind of reconnected. If they were able to continue benefits, they could stay on medications more easily. There's just all these things that are not only costing the sheriffs more, but are really ending up costing society more as well, because we're paying for it on the back end. And we know, in a lot of jails, while people, try to make sure that people get their blood sugar checked or, kind of, some basic things, a lot of jails operate on more of an urgent, emergent model where unless someone's really sick, they're not really getting to be seen, especially out in more rural parts of the country. I live in an urban area. We have a big hospital a few blocks away. It's pretty different, but I've did training in different parts of rural America and, have family in rural areas. And, I recognize that the nearest hospital, we're talking 20, 30 miles, hours, it may really depend on where people are. And so not having the payment structure really, we end up spending more because we're really dealing with the emergency that costs a lot more, and ultimately can cost people their lives. I mean, that's what it comes down to as well.
Yeah, especially with COVID now.
Mm-hmm.
I mean, I know that's a big topic, but we at the end of the day, we really are cost shifting,
mm-hmm.
right? We're moving the money from the federal government having the responsibility and the state governments and the governors having that obligation to fulfill. They're just pushing it all the way down the hill to the lowest point, and these are the most at risk people. That's the sad thing, is that it's preventable, and to me, it's all about safety and health of communities. And if someone breaks the law and they find themselves arrested, shame on them. That's a bad decision that they made. We all get that, and the viewers get this probably better than anybody. But at the same time, right, we know there's a 50% likelihood of them coming back through the system if they're at higher risk. And the higher the risk, the higher the recidivism rate. The higher the recidivism rate, the more likelihood of them causing some level of public health crisis, which is your world.
Mm-hmm.
And
absolutely. I think anybody that knew me in my time as sheriff, I was known to be a very tough on crime sheriff, and I believed in being tough on crime and protecting your communities. But I also believed I didn't want to be a warehouse for people. Yeah. All right, I didn't want to be a warehouse for inmates. I wanted to do everything I could to have them not come back. And I truly believe, I don't care whether you're tough on crime or not, your job is to protect your community. And as sheriffs, are we not protecting our community if we could all come together and develop the treatment systems that they need when they get out? The Medicaid systems that we talk about here that would pay for the treatment or continue their treatment. You don't fix heroin addiction or fentanyl addiction, that type of thing, in a matter of weeks. It mm-hmm. takes months and time. But if we could invest the time, everybody says it's just so expensive. Well, look what we're doing now, the billions and billions we're spending on a rotating door. Where if we could invest in the situation where they could maybe be sentenced, do their debt to society, but do it in a treatment center mm-hmm. that is, instead they don't even see one day in the jail, but necessarily they're being healed, they're being fixed, they're being and they become productive members of society, and they don't come back in through the revolving door. And everybody always talks about it's so expensive, and then we do things like where we drop their benefits, and it all falls on the county taxpayer, who's there's never enough budget dollars down at the local level, and now we're putting that kind of we're never going to fix this, and we're never going to change this if we don't start thinking bigger.
I think we can fix it. I know you wanted to talk about this. Mm-hmm. Is that legislation's coming through the Congress, and we've been working on a complete solution, which is just eliminate the exclusion in the law. We think that's the right answer. We think it's not only morally right, it's right for public health reasons. It's also right for crime and crime fighting and justice. The legislation that we're seeing now come from the Senate. And we're excited. For the first time, we're seeing a bipartisan approach. We're seeing Republican senators and Democrat senators saying we've got to do something. And as we were talking about earlier, this legislation it's not a panacea. It's the first step. It'll get people who are post adjudication back into the system by allowing that last 30 days, right, in care in jail or in prison. They'll be eligible again and then registered for Medicaid. It's a start, but we need to do something. And if we as a society don't, we always talk about, we don't want our jails to be warehouses, mental health crisis that it is. 50% of jails are mental health or coexisting conditions, right? Oh, nobody wants that to be. My
mental health coordinator used to tell me, Sheriff, do you realize you run the largest psych ward in North Dakota?
Right.
Because there was no other solution, and in some cases, family, I mean, how bad is it where a family member comes to you and says, please come arrest my son or my daughter and get them in jail where at least I know they're safe? That's not the answer. No. We can't jail our way out of those issues. And so it's really encouraging. And how does that make, when you hear that, so I want to hear your response to that, but then I also have a question, Jonathan, about that. So let's start with you, Dr. Silva.
Yeah, I mean, I think, I recognize that everything's politics, and that certainly, getting people back on their benefits before they leave is huge, because it means that you can transition people more successfully. But I think it is a drop in the bucket in a way, because, as you said, if we eliminate this exclusion, then effectively it would kind of revolutionize in a way what's possible in jails. I think when I think about our jail right now, I mean, we serve as a huge place for people with mental illness, kind of replacing in some ways old institutions from the 60s and 70s. And we, with the opioid epidemic, we are a huge treatment center and detox place. I mean, it's just, I think COVID has magnified it, not only because of this infectious disease, excuse me, but also because of COVID and the impact it's had on the healthcare system. People actually are not accessing healthcare right now either, or getting access to those benefits in the community. And so then they come in the jail and they haven't been on their medications for 6 months, which is sometimes typical. But I think more and more we're seeing sort of these ongoing effects of COVID in other ways. And so between sort of all of the actual just tangible health impacts, and then really I think within healthcare, there's more and more of a movement for not just looking at health disparities, but actually saying, how do we get equity? How do we make sure that this person and this person who are from different backgrounds and look different have the same outcomes when it comes to health? And we know that jails actually contribute to this, and not intentionally, but just by virtue of having disparate care. And, we could really change it from a place that's causing disparity to an opportunity, and say, how do we actually get people healthier and back on their feet and contribute to society, and not just have this be a repository for human beings.
One question I had, and that's great input, Doctor. One of the questions I have then, when you look at the average stay, and I've been out of sheriffing and looking at my stats in my jail for a while, but I think like the average stay of a county person is what, like 9 days, 10 days, or something like that. So does that mean when they come in, if it's their last 30 days, because that it never ends?
Great question.
Because I think that's something that should be presented to the legislature. That means then if somebody's serving less than 30 days, their benefits should not end when they walk through the door. They should just continue. And I think think of the thousands and thousands of inmates across this country in a county jail system, then that wouldn't lose their benefits. So on top of the last 30 for the prisons and the long-serving inmates, that will have a massive impact on those just doing a 10-day sentence for a DUI, or a 10-day sentence for a disorderly conduct, or a drunken public, something like that. They'll never lose their benefits, and that could be a big impact and really address a lot of what you just talked about, Dr. Silva.
Yeah, I don't want to tell anybody to circumvent the intention of the law. I think we're going to have to see the language in its final form, but I'm pretty comfortable saying that between NSA and other associations like NACO that we've worked very, very closely with on this thing, I think this is a first step. I think we can come back to it, because it's you raise a good point. What if we know that somebody is less than 30 days at the moment of booking? I could make the argument. I would make the argument. They're in the last 30 days of the sentence.
Exactly. That's the argument I would make as a sheriff.
He's going to apply. If he's on Medicaid, we can actually say, well, he's in the last 30 days. If the statistics in your jail show that 90% are there 27 days, well, you're inside that 30 day. That would be my argument. But our lawyers are probably, their heads exploding when I say this. So don't circumvent the law. Look at it and treat it as when it comes out. Look at it,
right.
Treat it.
And I guess my hope is when I say that is if it's being crafted, that is being taken into consideration and actually made part of it. That it's like, yes, if they check in and they're under 30 days for their sentence, they shouldn't lose their
if they had it.
If they have it, yes, and of course. And so, I mean, every little bit would help, and I think that would be a big part of it too. Because in the county jail, we're not talking prisons where they're doing 7 years, 10 years. We're talking, most do that 10 to 25 days at a county level. So, how would it change your environment, Doc, if this happened?
I mean, it would.
Can you give us some examples?
Yeah, no, I think there's a lot of things. I mean, I know for me, I make a lot of decisions. That's what doctors do. We decide a lot of things. We prescribe things, and I think there's a lot of disease cases, for example, with diabetes, really common disease. We see a lot of people with diabetes in the jail, and it it kind of limits what medications we tend to give. We have a fairly open formulary of drugs compared to some jails, but even so, with some of the newer diabetes medications that you see on TV and in ads and magazines and stuff, they do tend to be more expensive, and many of them are covered by Medicaid. But when it comes to paying it for them out of pocket, we're talking a couple $1,000s a lot of times per month. And it's a hard decision to say to someone whose blood sugar is maybe not that bad, should they have this medicine, knowing that it does have some other benefits, but they may not be here, they may only be here a couple months? Or do I say, no, we'll save that for somebody else? I mean, it's a lot of kind of wheeling and dealing and deciding sort of who gets what medicines. So, from a common chronic disease perspective, that's certainly the case. I think for mental health, certainly in terms of being able to provide some of the more expensive injectable medications and different drugs. I mean, I think that would make a huge difference. And then certainly I think all jails are also dealing with the opioid epidemic and figuring out, do we do MAT? Do we not? What's it going to cost us? There's drugs like Suboxone and, buprenorphine, which, depending on which version you have, can be $1 a pill or $8 a pill. I mean, they can be quite expensive, especially if someone's in jail for a while. Methadone's pretty cheap, but it's complicated because you have to work with other addiction clinics. And then there's naltrexone, which comes as a pill, but there's also the injectable Vivitrol is what it's known as, and that medication does tend to be kind of expensive, but there's a benefit. It lasts 28 days. It may be a good option for jails, but to drop that for every person who might need it also is something to consider. So I think having the ability to do some of these longer acting medications that might better serve these populations would be huge. But it does come at a cost. But then I think we have to think about what is the long-term cost of that, and in the end, is a deadly relapse, are some of the complications of heart infections and repeated antibiotics and all the things that then end up costing everyone, including that individual. Is that worth it? Where are we going to draw the line?
I don't know. There's studies out there that actually have shown the cost of what we're paying now for inmate health care in this country, and what's being spent at whether it's the local, state, or federal level, and what it would cost to make that turn and come to this. Are there studies done?
Yeah, there actually are. If you go to sheriffs.org, that's www.sheriffs.org, or naco.org. /first step, or not first step, stepping up. You'll see there's an abundance of research on this.
Excellent.
And that I think segues nicely to what we're asking the viewers to do, and that is get that information, learn about the legislation. We have time, fortunately, but we need the help. We need deputies, we need sheriffs, we need jail administrators, we need county administrators, we need doctors to be a voice of reason and advocacy in this, because as Dr. Silva says, these are conditions that can be treated low cost. There are conditions that, if not treated, can cause high costs. And so you're either going to pay it at the higher end or the lower end. If you're paying it at the lower end, as a former sheriff, Paul, you know this, you want these people trying to get back on their feet, trying to recover from those mistakes that they've made. No matter how much people want to say they are criminals, stipulated, but they are still going to be released into the community if they're in jail. That's a fact. And so how do we make sure that they are they have the resources to stay healthy and to do so in a way that doesn't harm our communities? And obviously COVID is changing a lot of that, and we could talk about that for hours.
Sure.
Absolutely. Well, and you bring up such a good point. And I think for so many years, jails were looked at as this like black spot, like, okay, that's over there at, in my case, it's over on, 34th Street and 4th Avenue. And let's just pretend it's not over there. Mm-hmm. When I had a 350 bed facility. So there were a lot of people in there that are members of our community. And you can't treat it like this little black spot. You have to accept that. And that's why we tried so hard to get, the volunteer programs and have members of the community coming in and stepping up and being a support base when inmates got out. Our chaplains programs, our Moms in Touch programs, our Dads in Touch programs, things like that to help them make them better. And you start mixing that with the healthcare and everything else. That's how you're going to change your community. And I would dare say as a sheriff, then that's how you're protecting your community. And I think we have to think bigger than just shut the door and forget they're in there, because when you open the door and put them back out there, they're a member of your community. Now, do you want them to go right back out and prey on your community, or do you want them to go out and be a vibrant member of your community? Well, let's help them become a vibrant member of the community. And that's why I think conversation like this is so important. And I think the engagement of sheriffs and jail administrators, be vocal, like you said.
Yeah, we need them.
Jonathan could do all. He represents the largest sheriff's organization in the world. And you are the voice of the sheriffs, but that voice comes from the backbone, which is the sheriffs. And we need to step up. We need to be involved. We need to be talking at the community level. We need to be talking to your state legislatures. You need to be talking to your congressional people. And we need to be a concerted voice. And that channel of that is through NSA and major county sheriffs and our chiefs, and use that voice. And let's make a difference with it. And then someday maybe we can have Dr. Silva come in here and say, yes.
Thank you.
Yes, thank you. And I think we have that responsibility and we have that duty.
Yep, I agree with you, Paul, 100%.
So, well, I can't thank you both enough for coming in. This has just been a neat time frame for us, for getting to have a chance to have you here, Jonathan, in your time frame, and we knew Dr. Silva was going to be coming. She had some free time, and I thought, what a perfect opportunity, first of all, for you two to meet after hearing each other's voices for all that time. But second of all, for us to do, we all have that same concern, is taking care of our county jails, making it a better environment, taking care of our sheriffs across the country, and taking care of people, which is your sacred oath. Mm-hmm. So I just can't thank you enough for doing that, and we really feel privileged to have you both here.
So as the guest host, do I get to say something?
You can say whatever you want.
You know what I'd like to do? I'd like to present you a mug on behalf of Jail Talk.
Oh, thanks.
But really what I'd like to tell you, what I'd really like to say is thank you. I wish Mark Stern were here sitting with us. You guys, you saved lives. You really did. And you didn't save just at-risk lives. You saved the lives of corrections officers, deputies. You made a difference, and you're still making a difference. And thank you seems so inadequate. And thank you.
Well, thank you for that, those kind words, and I'll also shout out to Dr. Stern. He's become a mentor, and certainly appreciate all of his help as well during this time.
And I'll just say what he said. I think we maybe sound like a broken record, but the impact you and Dr. Stern during that time was life-saving, and gave us a direction, and gave us guidance, and gave us a focus where we could go forth and do what we were trying to do, and communicate up to to the federal government, and communicate to our sheriffs. And we wouldn't have had that had you not stepped up and said, all right, I'm here, I'm part of the team, and we won't forget that.
And Paul, it wouldn't have happened without you and Jim Franklin, Steve Casey in Florida, and others that said we need to do this. And I gotta give a shout out. I know I was told not to do this, but I gotta give a shout out to Turnkey. They didn't even hesitate to lend you back to the nation's sheriffs, and it's a huge gift, and we thank you.
Well, I was honored to be called, and as I said, in one of our first episodes together, that I'll never forget the date and time of that phone call, because it definitely changed my environment. But I'm privileged to work for a company and to work for an owners in Todd and Tim Westby, that they didn't hesitate when I taught. They're like, hey, they need you. We serve the nation's sheriffs. Go, and we'll take care of your duties. Go take care of our country. And wow, I mean, what a privilege for me. And so I'm honored with the shout out, but it really comes down to Todd saying, go do this, and go, we're going to give him you. And for me, I'm never going to say no to taking to my brother and sister sheriffs out there. And, I bleed red, white, and blue, and you got to do what you got to do, and we all got to step up. And it was something I'm very proud of. So thank you.
Well, and I hope I did Lauren justice.
I think you did, and she's over there giving a thumbs up to you right now. And she, when we talked about this environment today, obviously the studio is only so big, and when you're doing something like this, you don't want a pack room full. And she just thought it was super cool, the fact that you both were going to be here. She's like, hey, I will step back and just listen to what they have to say. But I am going to make her proud, because I'm going to do her part here, and I am going to say, if you have questions, comments, or maybe even want to be featured on the show, email us at jailtalk@turnkeycorrections.com. And make sure you follow us on Twitter at JailTalk Podcast, and like, share, and subscribe to our YouTube channel to watch all of our podcasts, or listen on jailtalk.podbean.com. Now, I nowhere near did it her level, but I got it done. So thank you all for tuning in. I am Paul Laney. You've been listening to Jail Talk. We'll see you next time.